Welcome, ladies and gentlemen. I'm Dr. Silva. Thank you for joining me for this talk on QSYMIA, phentermine topiramate, a brand name only weight management combination medication that consists of a norepinephrine and dopamine reuptake inhibitor, phentermine, combined with a voltage-sensitive sodium channel modulator, topiramate. QSYMIA is FDA approved for chronic weight management as an adjunct to a reduced calorie diet and increased physical activity in adults with an initial BMI, body mass index, of at least 30 kilograms per meter squared, the definition of obese, or at least 27 kilograms per meter squared in the presence of at least one weight-related comorbid condition, such as hypertension or diabetes. Overweight is a BMI of 25 to 30, and obese is a BMI of 30 or greater in adults. QSYMIA is also approved by the FDA for chronic weight management, again with the dieting and exercise caveat, in pediatric patients ages 12 years and older with a BMI in the 95th percentile or greater, standardized for age and sex. And so in adolescents who are still growing, we don't simply look at the weight to stature ratio, at least in terms of the FDA sanctioning the use of QSYMIA. The adolescent must be at least 12 years of age or older and must be in the 95th percentile or greater in terms of their BMI. Phentermine. Phentermine is one of the phens in the infamous fen-phen combination, a weight loss formulation that was removed from the market due to cardiovascular toxicity. It was fenfluramine phentermine. The fenfluramine was found to be the toxic component. It was withdrawn from the US market in 1997 amid reports of heart valve disease and continued findings of pulmonary hypertension, including a condition known as cardiac fibrosis. It was banned in India the following year and subsequently withdrawn from other markets around the world, and the manufacturer ended up paying legal damages of $13 billion due to the potentially fatal complications. But phentermine was found to be safe, although it can increase blood pressure by increasing both dopamine and norepinephrine by blocking both transporters, i.e. reuptake pumps. When a neuron releases a neurotransmitter, one of the ways in which that neurotransmitter is cleared from the synapse, the gap between nerve cells where communication takes place, is by reuptake. The neuron that released it takes it back up again. And that's mediated through reuptake pumps or transporters, and it is a process that requires energy. You can block those pumps with medications, reuptake pump inhibitors, such as the SSRIs, the selective serotonin reuptake inhibitors, and doing so increases the concentration of those neurotransmitters in the synapse and thereby prolongs the action of that neurotransmitter and increases the intensity of the action. So in the case of phentermine, by blocking those pumps, it's mainly a noradrenergic effect, mainly norepinephrine. It does increase dopamine and also serotonin, but to a much lower extent than norepinephrine. And it's that increase in norepinephrine which increases blood pressure by causing vasoconstriction in the periphery. Peripheral arteries vasoconstrict, and that drives up peripheral vascular resistance and thereby the blood pressure. You also get an increase in pulse because of a direct effect of norepinephrine on cardiac muscle tissue. In the hypothalamus, however, dopamine and norepinephrine activate propiomelanocortin neurons, causing the release of propiomelanocortin, which is then broken down into alpha melanocyte stimulating hormone, which subsequently binds to melanocortin type 4 receptors in the hypothalamus to suppress the appetite. So this is an appetite suppressive pathway, and it's the same mechanism whereby bupropion, Wellbutrin, and stimulants in general, including Ritalin and Adderall, noradrenergic and dopaminergic medications that increase the concentrations of norepinephrine and dopamine, respectively, exert their anorexigenic effects. It's the same mechanism of action. It is an appetite suppressive pathway in the hypothalamus. However, normally, stimulation of propiomelanocortin neurons also activates an endogenous opioid-mediated negative feedback loop, which attempts to maintain homeostasis and mitigates this appetite-suppressing effect. This is why in the long term, With Wellbutrin, you see a weight-neutral effect. Patients don't usually lose weight on Wellbutrin. And even with the more powerful stimulants, you see the fairly rapid development of tolerance to this anorexigenic effect. Whereas Contrave pairs bupropion with naltrexone, an opiate antagonist, to disrupt this negative feedback, this homeostatic break, QSYMIA differs in that it contains no opioids, and so it has no effect on this negative feedback loop. Instead, phentermine, which, like Wellbutrin, is inducing anorexia via norepinephrine and dopamine, instead, phentermine is paired with topiramate, also known by the brand name Topamax, an anticonvulsant, which, in theory, through modulation of sodium channels, is thought to reduce stimulation of an appetite-stimulating pathway by glutamate, the main excitatory neurotransmitter in the central nervous system, and simultaneously increases inhibition of this pathway by GABA, gamma-aminobutyric acid, the main inhibitory neurotransmitter in the CNS. This results in a net inhibition of this pathway, this appetite-stimulating pathway. Okay, so it's a different pathway that, when activated, stimulates the appetite, but the net effect is to inhibit this pathway. And so you get an anorexic effect realized by inhibiting an appetite-stimulating pathway. Topamax all by itself is an anorectic. By pairing it with phentermine, we get a theoretical synergism with simultaneous activation of an appetite-suppressing pathway by phentermine, as per the foregoing. Phentermine is activating an appetite suppression via dopamine and norepinephrine, but topiramate is suppressing the appetite by inhibiting an appetite-stimulating pathway. Synergy is a greater than merely additive effect in which we expect to see a more robust and enduring suppression of the appetite than with either drug alone. QSYMIA is an extended release capsule taken once daily in the morning, beginning with the smallest denominations and increasing after 2 weeks, and then again after 12 weeks. If at least 3% of weight loss for adults or a 3% reduction in baseline BMI for pediatric patients is not achieved, the dosage can be increased again, and then a final time 2 weeks after that, to achieve the maximum dose combination of 15 and 92 milligrams phentermine topiramax respectively, which is still one extended release capsule once daily in the morning to avoid insomnia, taken with or without food. If at least a 5% weight loss in adults or a 5% reduction in baseline BMI in adolescents is not achieved after 12 weeks at the maximum dosage, the recommendation is to discontinue the medication. A further caveat is the need to monitor the rate of weight loss in pediatric patients. If it exceeds 2 pounds per week, a dose reduction should be considered. In a growing kid, height velocity needs to be monitored by the prescriber. Phentermine topiramate is associated with a reduction in height velocity in obese patients ages 12 to 17. Otherwise, monitoring should include regular measurement of resting heart rate, especially for patients with cardiac or cerebrovascular disease, or when initiating or increasing the dosage, baseline blood chemistries, and measurement of baseline blood pressure prior to starting and during treatment, especially, again, in patients being treated for hypertension. Women of childbearing potential should have a negative pregnancy test before starting phentermine topiramate, and monthly during treatment, and should be on contraception. QSYMIA is a teratogen. It specifically increases the risk of cleft lip, cleft palate, and that's due to topiramate. As a matter of fact, because of the risk of fetal toxicity, QSYMIA is available only through a risk evaluation and mitigation strategy program, a REMS program, with only certified pharmacies authorized to distribute it. The drug can cause irregular bleeding in patients on birth control, but this does not increase the risk of pregnancy. If spotting occurs, patients should be instructed to continue taking their oral contraceptive. Notable side effects include constipation, dry mouth, dizziness, dysgeusia, which is an abnormal taste. This is due to topiramate. I took Topamax briefly. What I noticed is that it made carbonated beverages taste flat. So the medication directly interfered with my tongue's ability to sense the carbon dioxide bubbles effervescing on my tongue. I didn't have a funny taste so much as an inability to sense the carbonation in carbonated drinks. It certainly put me off of drinking soda, so maybe that was a benefit. And insomnia is also a common side effect. Cognitive impairment due to Topamax is another concern. This risk is greater with rapid titration or high doses, especially at the outset of treatment. So that can be mitigated by following the titration schedule. In overdose, you see restlessness, tremor, hyperreflexia, and rapid respirations with phentermine, culminating in panic, hallucinations, confusion, and/or aggression. Whereas topiramate overdose can lead to a severe metabolic acidosis, paradoxical convulsions, sedation, speech disturbances, blurred vision, or diplopia, double vision, hypotension, low blood pressure, and other signs of toxicity. QSYMIA has been evaluated in controlled studies lasting up to 1 year. Topamax is not a controlled substance, but phentermine is classified as a Schedule IV drug under the Controlled Substances Act, meaning that there is some abuse potential. That's a Schedule 4 out of 5, with 5 being the least habit-forming and carrying the lowest risk of abuse. For patients on the maximum dose, weaning prior to discontinuing the medication involves taking a dose every other day for at least a week to minimize the risk of precipitating a seizure, especially in those patients who are at greater risk, either because they're taking other medications that lower the seizure threshold, or those patients who may have a history of seizures. Sudden, unexplained deaths have occurred in patients with epilepsy. Other potentially life-threatening or dangerous side effects include hypoglycemia, low blood sugar, tachycardia, which is an increased heart rate, metabolic acidosis and kidney stones. This is due to the inhibition of the carbonic anhydrase enzyme, and other more rare complications. Contraindications include pregnancy, if a patient has narrow angle glaucoma, angle closure glaucoma, and hyperthyroidism, or is taking an MAOI, a monoamine oxidase inhibitor. This is due to a risk of hypertensive crisis. A syndrome consisting of acute myopia, nearsightedness, has been associated with secondary angle closure glaucoma. This has been reported in both adults and pediatric patients. A sustained increase in resting heart rate indicates a dose reduction or consideration of discontinuing the medication. There are lots of drug-drug interactions that are well beyond the scope of this presentation, but prescribers beware. Risky populations are patients with a history of kidney stones or those who are at risk for metabolic acidosis, women who are pregnant or wish to become pregnant, and patients with a history of stimulant use disorder or past stimulant abuse. Does it work? If it does, then we need to see at least a 3% weight loss by about 14 weeks with an expected weight loss of at least 5% after an additional 12 weeks on the maximum dosage. In general, patients might expect to achieve a 5 to 10% reduction from their baseline body weight. Phentermine topiramate should be administered in conjunction with a reduced calorie diet and increased physical activity, and should be discontinued if 5% weight loss is not achieved after 12 weeks on the maximum dosage. Prior to the GLP-1 agonists like Wegovy and Mounjaro, QSYMIA was perhaps the most effective FDA-approved drug for the treatment of obesity, but now it's tirzepatide far and away. Thank you for watching. As always, questions and comments are welcome.